I'm happy to do so. Should
Yes,
I?
yes, sir. Thank you.
Sure, sir. Thank you, sir.
Okay. So, okay. So good evening, everyone. I hope you can see my screen as well as you can hear me. Okay. Yeah.
Yes, sir.
So thank you, Monica and the rest of the team in India for inviting me to give this talk on surgical considerations, challenges, and outcome of neuroblastoma excision. And as you know, I practice in Singapore. It's a small country, but I think I had the privilege of seeing patients from around Singapore who come to Singapore and share this experience with me. All right. So firstly, I think some of the things that we will be talking about today will be the chemotherapeutic effect on IDRFs, surgical considerations as per site or per IDRF, contraindications for surgery, and the impact or referring to the adverse impacts of extensive dissections. Before we do that, let's touch on the principles of neuroblastoma surgery. I think a lot has changed over the last 30 years. There's a lot has evolved. Firstly, I think we all know from more than 20 years ago that MYC-N amplification is a very important prognostic factor. Together with that, recent years, we know that the segmental chromosomal aberrations seem to be very important as well as a bad prognostic factor. And at the same time, besides having surgery, radiotherapy, chemotherapy, we now have immunotherapy as part of the treatment regime, especially for high-risk neuroblastomas. And then together with that, there are also other new modalities and some of the not so new ones, certainly on the right-hand diagram includes the MIBG as well as other things like CAR T cells treatments have been experimented. Now, the hallmark of neuroblastoma is heterogeneity. They can present as neonates, infants, and we know that this group actually have very good prognosis. Some of the very young ones actually have a chance of having undergoing spontaneous regression. So we know there are localized patients, localized tumors, metastatic tumors, tumors that produce hormones. Some of them have paraneoplastic syndromes, and certainly the tumors may be at different sites. So in essence, no one tumor is the same between patients. And the surgical risk factors, as we just now highlighted, is what we nowadays call image-defined risk factors, or IDRFs. It has been published about 2009. That's when it was first described, and then subsequently a lot has been said or published about the IDRFs. Biological markers, as I said earlier on, they are very important nowadays because that determines or has been very important for us to decide which patients are good players and probably adjust our surgical strategy. This tumor, neuroblastoma, is very chemosensitive. As you can see in this patient that I've just shown, before chemotherapy and once you treated the patient with chemotherapy, the tumor can shrink tremendously, all right, and making surgery much easier. And the surgical goal, not to forget, is to remove the primary tumor and the enlarged lymph nodes in the region without mutilation. And adequate surgery is really the R1 resection. And we are allowed to remove them in segments, and a lot of times spillage, we feel that spillage is allowed because these tumor cells do not implant into the peritoneal or the pleural surfaces compared to like other tumors like Wilms tumor or the sarcomas. And these very often surgical margins are involved. And so most of the time we aim for complete macroscopic resection, gross total resection. And in the high-risk groups, it has been well published these few years that we should achieve more than 90% resection. We do biopsies for many of these, and we can actually perform needle biopsies, core biopsies, or by open techniques as well. And so now let's touch on the strategy. Yes, the IDRFs on the right-hand side is a table of about 20 of them. And these IDRFs has been described, tested, and it seems to affect outcome adversely if they are present. And these are really surgical risks and complications. And their presence may affect the completeness of resection. But they are not contraindications to surgery. Okay, we will explain a little more on that later on. And so, in the presence of IDRFs, we will suggest giving chemotherapy upfront and then followed by surgery. I think this is really quite dependent on the individual surgeon, because some IDRFs may seem to be easier to tackle, or do not need upfront chemotherapy to avoid these IDRFs. All right. So the staging has changed from stage 1, 2, 3, 4 to L1, L2, M for metastatic disease, and then MS. Now, so this in case number 1, this is a 3-year-old girl presented with cough. A chest X-ray showed very localized right paravertebral tumor. And for this patient, neuroblastoma is a suspicion, and I wouldn't want to go for any other further tests, including a biopsy, and I would offer the patient upfront surgery, especially when the patient has no other symptoms. Now, case 2 on the right-hand side is a 3-month-old boy antenatally diagnosed to have a left adrenal tumor at 36 weeks of gestation. At birth, ultrasound scan was done and confirmed this tumor, and subsequently an MRI done a couple of months later showed that the tumor has increased in size. So in this patient, I opted to perform an upfront surgery. Now, so upfront primary surgery, there are contraindications. So definitely in the presence of metastatic disease, I would suggest avoid upfront primary surgery. Because of the metastases, we often need the chemotherapy to control these metastatic cells and be able to control the disease well. At the same time, the chemotherapy would actually help to shrink the tumor as well as put the patient in a better condition for us to perform the surgery. And in the presence of tumor hemorrhage or rupture, I think gone are the days whereby we have to perform heroic surgery to suffer great amount of blood loss and perform a surgery and yet not be able to complete the resection. All right. So we should, in the presence of tumor rupture or hemorrhage, we should give upfront chemotherapy, and we should be able to have an opportunity to perform surgical resection later on. Now, the IDRFs, I have grouped them into 5 groups here, and they include those that encase the vital vessels, those that occupy multiple compartments, those that invade or infiltrate contiguous organs like the kidneys or pancreas, or significant spinal extension, and airway compression as well as what we see in the scan pictures. Now, neoadjuvant chemotherapy, we know, helps to reduce tumor volume, and not only that, it also reduces IDRFs. However, we found reports mentioning that there's no reduction in IDRFs have been found between 18 to up to 68% of the patients who were given neoadjuvant chemotherapy. And we also know that these IDRFs, there are IDRFs that may be refractory to chemotherapy. And this is especially so in situations of patients who have histology of ganglion neuroblastoma, patients who have low or intermediate risk, intermediate MKI, and IDRFs of the renal pedicle, the SMA, the celiac axis, aorta, and the cava. Now, this is a paper published by our Korean colleague who saw that in MYC-N amplified tumors, many of them have great reduction of tumor volume. But if you see in the yellow boxes, there are still a certain number of patients who fail to respond to neoadjuvant chemotherapy. And so are the undifferentiated tumors. They tend to respond better to chemotherapy, but again, there are a few of these that will not respond to chemotherapy and make a surgeon's life, surgeons' work very difficult. Now, this is a 4-year-old girl whose tumor was very resistant to chemotherapy given 8 cycles of Kojak. It was a non-metastatic differentiated neuroblastoma. MYC-N was not amplified. There were many IDRFs. And so in the end, as surgeons, we are still given this kind of situations to deal with. And we still have to think of ways to excise these tumors. So next, we deal with the challenges. So first thing is that we all know that neuroblastoma encase blood vessels. And we also know that Professor Ed Kiley in Great Ormond Street in London many years ago described this technique of subadventitial dissection. And he wrote very clearly that, yes, we can remove these tumors in segments. And the other main point here is that we should also expose these blood vessels well. All right, so the understanding here is that there are 3 layers to the blood vessels, and there is a plane that we can identify, plane of dissection that exists beneath the adventitia. Right, so, and the other point that we were getting at is that always identify the normal looking vessel and then work upwards or work towards the part that is being encased by the tumor. And the whole idea here is to have systematic exposure of blood vessels so as to not accidentally cut into the major blood vessels that we wish to preserve. And certainly, after some time, we all have to be able to identify which layer is the intima. Now, in this picture, the yellow, the part that's that's indicated by the yellow arrow, is the area you notice that it is fairly avascular. And when you reach a layer that is fairly avascular, fairly pristine white, you know you have gone too deep. So try to cut less, all right? So in such situations, sometimes it's worthwhile leaving a bit of tumor onto the vessel, and so that you don't get into this problem of accidentally cutting into the aorta. And Mike LaQuaglia in New York has also, his group has published this paper on situations whereby they have to subject the patients to aortic grafting. They use a PTFE or Dacron grafts, either tube grafts on lay patch grafts. Right? So I don't have much experience in this. I have had one situation whereby I cut the aorta and we had to get my vascular surgeon colleague to come and assist me to patch up. And that's the picture on the right-hand side with the yellow arrow pointing to the graft. Now, next is nephrectomy. We all know that neuroblastomas the location, especially these so-called image-defined risk factors here shown in this slide, may predispose these patients to finally suffer from having to undergo a nephrectomy. All right, these include those that narrowed up the renal artery, encase the renal vein, infiltrate the hilum, as well as also directly infiltrating the kidneys. Now, we know that if we are able to preserve the ipsilateral kidney at surgery, they all have superior outcomes or better outcomes compared to those that have had nephrectomies. And Bob Schamberger many years ago also published a paper telling us that pre-op chemotherapy does actually reduce the number of nephrectomies. All right, so therefore, in situations where these IDRFs that may predispose to nephrectomies, we should all give preoperative chemotherapy, and we hope that we can actually avoid causing the loss of a kidney. Now, so next, I want to show you this video. All right, there's a 2-year-old boy with MYC amplified neuroblastoma, L2 non-metastatic disease, received 4 cycles of high-risk chemotherapy. So you can see that the tumor actually encased the renal vessels. So I've just dissected the pancreas off, and they're now handling the tumor. Now, the main part of this surgery is really to identify the vessels layer by layer. So over here, I'm working on the renal vein, right? So, and remember, it's piecemeal segmental resection. We clear it until the veins and the arteries are exposed, right? So I usually use scissors when I come to the renal vessels. I do not use diathermy at this stage. If I need to cauterize, I use bipolar. All right, so you saw me removing segments of the tumor, and then finally at this stage, you can see the renal artery and its branches. It's really very fine dissection until we get to the fine branches of the renal artery. Right. So I use this. This is a tenotomy scissors. I like this because it looks sharp, but at the tip, but it doesn't injure its neighboring structures. And because it is slightly blunt tip, I can actually dissect using it as well. Right. So this you can see, I finally cleared the tumor away from the renal vessels. Now, next, so we also know that in high-risk neuroblastomas, in the study done in the CellPen study, we should try to avoid or postpone nephrectomies because we found that with kidney still present, these kids probably handle high-dose chemotherapy much better. And they have also found that delaying or postponing the nephrectomy until after the high-dose therapy makes no difference in its outcome, whether it's event-free survival or overall survival. Now, next is we look at the midline perivascular IDRFs. And in this group of tumors, Stefano Avanzini from Italy has actually published years ago that this is considered what we call unfavorable unfavorable region with unfavorable surgical outcomes, event-free survival, and overall survival. All right, so because this area, the tumors are in cases, the celiac axis, SMA, and the other branches, the mesenteric branches. All right, so and I would touch on this group as well, which is just what we just mentioned, the hepatoduodenal pancreatic neuroblastomas. And the main surgical challenges is that pancreatic involvement here. Whenever pancreas is involved, it can be either solitary or diffuse involvement, as you can see in the scans at the bottom. All right. So, and at the same time, together with that, these tumors also encases the aorta, celiac axis, the SMA, and the renal arteries, even if the pancreas is spared, as you can see on the diagram on the right, right? And these tumors very often lack response to chemotherapy. And so let's go back to the basic anatomy about on this area. It's really the tumor actually arises from this network of celiac and the superior mesenteric ganglia, as well as its branches. All right, so you can see the branches hugging around the various branches of the vessels, and you can imagine when these network of nerves develop into tumor, they really cause a lot of problems for us as we perform neuroblastoma resection here. So therefore, in a typical case like that, so that encases so many blood vessels, I would suggest doing it stepwise. Number one is to identify the infrarenal aorta, because that's usually the area that is not encased, and you can use that as a guidance to work upwards. Then in diagram 2, that's where we identify the splenic vessels, the renal veins, the IVC, and that's where you'll also be able to hopefully identify the posterior edge of the pancreas. Then diagram 3, after that, I switched upwards and went above into the lesser sac of the stomach. And that's where I dissected the hepatoduodenal ligament and be able to free that area, and very importantly over there, identify the common hepatic artery as well as the other blood vessels. And finally, then I go on to the left side of the patient and then to clear the tail of the pancreas as well as the left side of the para-aortic region. All right. So these surgeries are usually very long, very tedious, and it will take many hours, more than 10 hours usually. Now, next, we deal with tumors that have difficult surgical accesses. For example, the cervico-thoracic tumors, whereby we do the trapdoor anterior thoracotomies. Sometimes apical thoracic tumors, we also use trapdoor, which I find very useful. Then thoracoabdominal tumors, and I will show you about doing it with the thoracoabdominal incision, or sometimes using a dual approach, a laparotomy and a separate thoracotomy, or even working through the diaphragm from the abdomen. And this is the trapdoor anterior thoracotomy that I reported years ago. This is just a very short video showing you a 5-year-old boy with an L2 tumor on the left side. So that was after clearing the neck, and then I did a sternotomy, median sternotomy, and then opened up the trapdoor here. Soon after that, the first part that I'm going to identify is really the phrenic nerve. Identify the phrenic nerve because that should come in view very soon. And once the phrenic nerve is cleared, in this patient, the tumor is really, after chemotherapy, melted around all the structures, right? So, so then the common carotid, and subsequently, next to the common carotid is the vagus nerve. All right, so now is to dissect below the brachiocephalic vein, right? And so this is really dissecting along the vagus nerve. So when we dissect the nerve, and the technique is exactly the same as dissecting around the vessels, and that is to go on the surface or the nerve sheath and dissect it down. Okay, so you can see that this is really like an anatomy dissection, dissecting all the structures until everything is clear. And this is the subclavian artery. And usually once after the subclavian artery is identified, then next is to identify the vertebral artery that usually arises from the subclavian. But this part of it is just behind the vessels. That's where the tumor is. And this is resecting the tumor. And at the end of the surgery, we should be able to identify the nerves, then the vessels very clearly. All right. So next is another publication on thoracoabdominal neuroblastomas. And this is a 2-year-old girl with a thoracoabdominal tumor, L2, no amplification. Chemotherapy didn't really change the size a bit. So this is after opening up the chest and then identifying the edge of the diaphragm and then cutting the diaphragm onto the tumor until we can expose the borders of the tumor, right? So so once that's done, you can see the kidney over there is actually just dangling from the diaphragm, and then just cut around the periphery of the diaphragm and until the tumor borders are well identified, and this is on the medial border. And now looking at the aorta and using scissors to dissect it. Well, on the scan, it looks like it's encasing the aorta, but actually it's just sitting next to it, side by side, adjacent to it. And it was not difficult to separate it. And next is to, now when the tumor is too big, I usually like to cut it into smaller pieces and create space for myself during the dissection. And so that was after the tumor was removed, and then now clearing the intercostal tumors. Now we talk about the intraspinal extension. We know that most of these are actually low-stage tumors. They are more likely to be thoracic tumors, less abdominal tumors, and they usually have more favorable histology. We also know that since long time ago that chemotherapy is a very good alternative to laminectomy and radiation in the management of epidural tumors. And they found that there's no significant difference between chemotherapy and doing surgery in terms of its ability to relieve neurological deficits. But we also realized that there are more motor sequelae after neurosurgery, and spinal deformity are strongly associated with neurosurgical treatments as well as radiotherapy. Therefore, most of the protocol recommendations would be cord compression can be effectively managed with upfront chemotherapy. We limit neurosurgery to patients with rapid neurological deterioration only, and initiate treatment before symptoms have deteriorated to complete loss of neurological function. All right, so this is another example, a 13-month-old girl who presented with lower limb weakness for 6 months. Her parents did not realize that the limb weakness was an abnormality. So this was an L2 tumor. Biological markers were good. 4 cycles of chemotherapy, minimal tumor size reduction. And this one, during the neurosurgeons did on a separate day, and then while we did on another day to clear the intra-abdominal tumor. And I did it with neuro monitoring. All right, now, lastly, we deal with some complications. And I think I put up this chart. There are many complications. Some of them are short and intermediate term. Some of them are long-term complications. And I divided them into systems. The vascular ones, we have short primary hemorrhage. And this is usually associated with the surgery itself. And this is usually quite soon after the surgery. Secondary hemorrhage can happen, say, after a week or more. And we'll show you some later on. And then chylous fistula usually is short and intermediate term. Renal atrophy, when it happens, you may be able to identify that in the intermediate term, and this actually carries on to long term. All right, respiratory complications are usually short and intermediate term. Gastrointestinal complications like intestinal obstruction or diarrhea, they can happen short or long term as well. And then hepatobiliary complications, endocrine complications, neurological complications as well. All right. So this is a patient who had stage 4 neuroblastoma after chemotherapy. I did surgery, and then within 8 hours she started bleeding, and the drain actually had lots of blood, and there was low blood pressure. So I went in and I found a bleeder, a small bleeder from the diaphragm. And once it's cauterized, the bleeding stops. So sometimes these things do happen. All right, so this is a patient whom after on day 5 had massive melena as well as hematemesis, and did a OGD and found him to have a duodenal ulcer. And this patient actually was 4-year-old male, stage 3 neuroblastoma, very large tumor, and after the surgery developed on post-op day 8 a collection, and subsequently another 10 days later, he developed a massive secondary hemorrhage and wasn't salvageable. So there was just massive bleeding. All right. So we think that this is probably probable cause was probably either from a biliary fistula or anastomotic dehiscence or pancreatic. Well, I mean, in this case, patient, there was no anastomotic dehiscence. More likely, we were suspecting whether it's a pancreatic or biliary fistula here. Now, next group will be chylous fistula. It has been talked about in every conference. I think this year there were several papers on this at the IPSO conference as well. Now, so the usual treatment is conservative, MCT diet, TPN, octreotide, we can still continue with chemotherapy. In the worst situations, we may have to perform surgery to stop this. All right, so you can see the cowlick, and in this, and on the right picture, if the patient has had some milk or creamy stuff before the surgery, you will actually be able to see the lymphatic ducts light up white in color. All right, so Sajid in Mumbai actually also published a paper whereby he reported 20% of cowlick, and all of them were treated with conservative management, and their chemotherapy was not delayed because of the cowlicks. And this is the paper that I presented years ago about performing mesenteric lymphatic ligation. And I found this useful. That means immediate after the surgery, look at the mesentery, especially near where the SMA and the celiac axis is, because I feel that that's where all the chylous fistula would develop. And I learned this from the few operations that I performed in chylous fistula. And those chylous fistula, before I reoperated on them, I made them take fatty food, cheese, cakes, and things like that. And during surgery, all the areas that lighted up most, or where I see white fluid coming out from, were actually around the mesentery at the SMA and the celiac axis. And that's why I concluded that we can also do a preventative prophylactic lymphatic ligation at the conclusion of our abdominal neuroblastoma surgery, so that we can avoid having to manage chylous fistula after that. Now, these are patients who had renal atrophy. You can see actually the pre-op CTs already that the kidneys were not too normal, and the tumors were encasing the vessels. And after surgery, the patient on top had a kidney that was very, very small, and the patient at the bottom, the kidney just disappeared after 6 months. Now, chest complications, we get pleural effusions. Some patients we get phrenic nerve palsies, especially if we have performed a thoracic neuroblastoma resection and unknowingly injured the phrenic nerve. All right, some of them do get pneumonias because they sometimes don't started with very poor respiratory effort or atelectasis, and then they develop pneumonia and effusion. This 2-year-old female had a mediastinal neuroblastoma, probably also causing bronchomalacia and lung hypoplasia. So after surgery, the upper lobe collapsed, and after that, we put the patient on CPAP, and then the lungs open up again. Now, intestinal obstruction is something we deal with quite often, and I have been trying to, when it happens and it requires surgery, I have been trying to use laparoscopy. And I find that it works, and it works well, and with laparoscopic adhesiolysis, the chance of a recurrent intestinal obstruction is very, very low. All right, and so this is on the pancreatic and duodenal pancreatic block, the complications. And this patient actually had a pancreatic fistula after I did a distal pancreatectomy for a neuroblastoma that was involving the distal pancreas, right? And this is a girl who had dissection around the pancreatic head as well as the bile ducts, and then ended up having a biliary stenosis, and we did a percutaneous transhepatic stenting. Once we stented the duct for about 2 weeks, and then we withdraw the stent, and then the child was fine. All right, and this is artery of Adam-Kiewicz. A lot has been spoken about this in the last 10 years or so, especially in tumors involving the lower thoracic region, T9 to T12. And this is because of the presence of artery of Adam-Kiewicz. I have experienced not knowingly ligated the artery of Adam-Kiewicz, and the patient actually became paralyzed. And other nerve complications, this is one of them, a Klumpke's palsy. This when the brachial plexus is injured in the process of a trapdoor tumor resection. So last slide, a summary is that the surgical principles, gross total resection or R1 resection, no mutilation, and the technique is subadventitial dissection. And we have dealt with talk about some of the risks and complications. These operations are tedious, long operations, and they are not without complications. And besides completing the surgery, we often have to tell parents the next part of the recovery is to manage the complications. Okay, I thank you for your attention. I'm happy to take questions if this is the right time to do so.
Thank you, sir, for such an elaborate webinar, for such an elaborate talk. So you have covered all the intricacies of surgery, complication and all, and it was really enjoyable to watch this. So I had discussion with Dr. Monica in between, and she was enjoying it. So thank you for this, sir. So we'll take the question in the last, sir.
Okay.
So next talk, I will invite Dr. Vikramjit, sir. He is Chief of Pediatric Oncology at the HBCH Varanasi, and he is Associate of PHO Journal of IAP and a Pediatric Hematology Editor for Medscape. So, sir, he will elaborating on the recent advances in chemotherapy and management of neuroblastoma. Over to you, sir.
Sure. So let me go ahead and share my screen. In the meanwhile, thank you, Dr. Chan, for an excellent talk. That is probably the best talk I've heard in a long time on surgical complications and surgical approach to the surgeon is truly our best friend when we're dealing with neuroblastoma patients. So although I'll be talking a little bit about what we do, and I see Saumitra nodding his head vigorously. So yes, it's okay, so some of this I can skip over because Dr. Chan has very thoughtfully summarized many of these things. But again, I'll just emphasize the biology of the underlying tumor really plays a big role in how we approach these patients. And although some of them, like, low risk, intermediate risk, will, regardless of how much you surgically resect, will do well. The majority, unfortunately, are much more aggressive and need aggressive treatment all around. Once again, this has already been covered in the last talk and by Dr. Chan. And the risk stratification is constantly being modified and tweaked. But there are some key things which still stand out. And I think the challenge is in getting lost in the wood for the trees, that it's possible, like, COG created about 17 cohorts, and then eventually simplified it down to the fact that high-risk patients, what I'll primarily be talking about, is all patients who have MYC amplification, all patients who are metastatic more than 18 months of age, if they have IDRFs L2 more than 18 months and unfavorable histology, or if they have loss of heterozygosity as a risk factor. Some of those may be high risk, some may be intermediate risk. The low and intermediate risk patients are easier to cope with. You're looking at chemotherapy, typically carboplatin etoposide based, followed by cyclophosphamide, vincristine, doxorubicin, so-called JE/CADO. The intermediate risk group of patients, which includes most of the L2 patients, are often the hardest to cope with because there's such an amount of heterogeneity in how they respond. And some patients after resection, if it's a small amount of resection and they're biologically aggressive, even end up getting radiation therapy, but we try to confine ourselves to surgery and chemotherapy, given the age of these patients. So the trigger for chemotherapy in the low-risk patients is life-threatening symptoms. And life-threatening symptoms, and again, this has been covered by Dr. Chen, intraspinal neuroblastoma compressing the cord, like, GI symptoms where vomiting needs nasogastric and IV support. It's important to remember that patients who have profuse diarrhea, so-called Kerner-Morrison syndrome, may not respond well to chemotherapy. And it may be important to look at surgery sooner rather than later. Respiratory distress, cardiovascular symptoms, renal symptoms, hepatic, DIC mass effect, causing bladder and bowel dysfunction, and concerns about imminent rupture or patient duration. So there's a long list of life-threatening symptoms which will cause you to initiate chemotherapy regardless of the risk category. Nevertheless, how they do will depend on underlying biology. This is a work in progress. I just put it up to mention that INFOG will be looking at low-risk intermediate-risk protocol, which my colleagues are developing. So in high-risk neuroblastoma, the challenge is overall poor outcomes. Like, less than 50% event-free survival, despite the so-called standard treatment. So rapid Kojak cycles, which is 6 cycles of high-dose chemotherapy, surgery of the primary tumor, busulfan, melphalan, intensive chemotherapy, followed by autologous stem cell rescue, radiation to the tumor bed, and even to any lingering metastatic sites which were not in remission at time of transplant, but no more than 5 sites. Immunotherapy has made a big difference in terms of outcomes, but in terms of how much difference, it's probably about 10% event-free survival, 10 to 15%. And the challenge with high-risk neuroblastoma is these are so-called cold tumors, which evade the immune system. They're an immunosuppressive tumor microenvironment. They downgrade any sort of antigens expressed by natural killer cells and are almost invisible to our normal immune system. And the neuroblastoma cells themselves express high levels of ganglioside and so-called GD2 sort of molecules, which are immunosuppressive when they shed into the tumor microenvironment. In the form of a small cartoon, this just gives you an idea as to the different mechanisms which can be used to attack a neuroblastoma tumor cell. If you look at the bottom, you can see the antibodies listed. And so you have mouse 3F8, which was initially developed in Sloan Kettering, the humanized 3F8, naxitamab, CH14.18, dinutuximab, which is a chimeric molecule combining mouse and human entities, and humanized 14.18K322A. And the thing to look at is all these molecules are not identical in the kind of immune response they generate. Nevertheless, all of them seem to generate the same amount of benefit in terms of improvement of event-free survival, and they seem to do so by different mechanisms. So mouse 3F8 uses complement-mediated cytotoxicity, whereas if you look at CH14.18, it's more dependent on antibody-dependent cell-mediated cytotoxicity. So these, again, the original studies go back over a decade now, probably almost 2 decades, with regards to immunotherapy. And Sloan Kettering has been using 3F8 for a long time. The humanized version is interestingly a little, maybe marginally less effective than the mouse antibody. Radioimmunotherapy with iodine 8H9, omburtamab, is something which I certainly have not used personally. Like, it's been used in patients with the CNS relapsed neuroblastoma. And the reason it's so far, its trials have been confined to CNS compartment, etc., is the omburtamab molecule is one that binds to neuroblastoma cells, but it also has off-target toxicity, particularly the liver. So this is something which so far, at least in trials, has been used in a confined setting. But in the future, related molecules may be used more generally. So in terms of the benefit from using... I know I need to wrap up. Yeah. So in terms of the benefit, so you can see now that on the right, you have your Kaplan-Meier curve. And with regards to outcomes, like, when St. Jude added CH14.18, not just post-transplant, but also pre-transplant, they got event-free survival curves in excess of 60%. So there is a question of is more better, but cost is the main issue which confronts us. Other molecules being used, DFMO is one which is under trial. It's certainly not available in the public domain yet. And it's something that helps down-regulate ODC1, which is a target of MYC gene and the rate-limiting enzyme in polyamine biosynthesis. So the main thing to keep in mind is these are not benign therapies. Immunotherapy, they have fairly severe side effects. So institutions which use them and can afford them need to be employing them, but this is not something which should be used as a one-time by somebody who's unfamiliar. Severe nerve pain, capillary leak syndrome, anaphylaxis, these are all notable side effects that are seen. So, and that's it. So thank you very much, and I apologize for not being on time, but I thank Dr. Chan for stepping in.
Thank you, sir, for such a concise view of this recent treatment guidelines. But for India, where resources still limited, we still have to use the old gold chemotherapy, and still high-risk neuroblastoma has got the prognosis of not more than 40 to 50%. So once these are available in India freely, so we may be using these things. Still obvious that we don't have this support system to deal with all these things like immunotherapy side effects and all. So it's still a future for us.
I understand, which is why this talk was so brief, because
yes,
the challenge is these are all things like pie in the sky that we would like to use them, like, but we don't have access to them. They're extraordinarily expensive.
Yes, sir.
And we don't have any open clinical trials, which also allow us to access them, say, like the blinatumomab trials, which are where the company is supplying the entity to one or two centers. So we're left using then retinoic acid, which is at least affordable. And with that, we know we can get approximately about 40% survival in patients if you have, like, standard induction chemotherapy, rapid Kojak cycles, along with a good pediatric surgeon, like, along with the transplant unit that's familiar with autologous transplant, along with a radiation therapist who can administer, post-transplant radiation treatment. So you're absolutely correct. In our setting, the main challenge to us is we would hope in the next few years to see some of these entities coming our way, but practically day to day, we are limited to like, our so-called standardized approach where the only immunotherapy you can really do is retinoic acid post transplant.
Yes, sir. So, sir, we'll take the question the last. So, we'll just go with a few case scenarios. We'll just take 3 or 4 cases. So, can I share my screen? Are my slides visible?
Yes.
Yes.
Yeah. Take the first case. A 2-year-old female child, presented with mild respiratory distress and cough. There was no fever. And on chest X-ray, we found there was a small globular mass on the right upper chest. On imaging, this was a cervico-thoracic mass with IDRF in the form of tumor encasing brachial plexus root, tumor encasing subclavian vessels, and tumor compressing trachea. In view of and bone marrow aspiration biopsy are not involved, and according to stage, INR stage, this was stage L2. I'm just going a bit brief. So, my question to Dr. Chan, how do you approach a case of cervico-thoracic neuroblastoma?
Yes, very good question. Very nice case. So I would actually, if there are no suspicion of metastasis, I would actually go for an upfront right trapdoor thoracotomy. So I want to caution everyone that in this patient, these are all so the cervicothoracic dual compartment is considered an IDRF. The fact that it may be compressing onto the trachea is also an IDRF. So you have all the reasons to give upfront chemotherapy as well. All right. So I think it really depends on the surgeon how comfortable they are performing like a trapdoor surgery, and this tumor actually can come off quite nicely just with an upfront surgery. Yeah.
So, next question, Dr. Vikramjit. We
Go
have
ahead.
we have gone with the few cycles of chemotherapy followed by surgery. So, how would we move further? What is prognosis of this kind of case, like in terms of disease biology?
Oh, this is a more challenging question than So
Yes, sir.
the underlying prognosis will depend significantly on what is resected. So in other words, about 20% of L2 patients is going to be MYC amplified, but 80% are not. And so 80% tend to be usually relatively good biology. You have about a fifth of patients who, unfortunately, for a variety of reasons, like they may MYC amplified, we have unfavorable histology, which are going to need chemotherapy. The question is very often, if somebody's been resected up front, how many cycles of chemotherapy should you give at the back end? And what kind of chemotherapy should you give? And that will be driven by the pathologist and by the molecular pathologists who have analyzed your tissue and can tell you what you're dealing with. So if this, for example, is not NMIC amplified, I'd be very comfortable giving maybe 2 to 4 cycles of carboplatin etoposide and just stopping there and observing, and following some sequential imaging. If on the other hand, this is shown to be a high-risk tumor, then you're looking now at much more aggressive treatment.
Thank you, sir. So we'll move to the next case. So this was a 3-year-old female child, child with osteoclast, myoclonus, and irritability and gait instability over last 7 to 8 months. So worked up and treated with primary care physicians for seizures, idiopathy, and all, but symptoms progressed and it presented very late. MRI was done. MRI brain was done 2 months back, was normal. So I was referred by a certified pediatrician, and imaging showed a axial left paravertebral mass lesion 2 into 1.8 centimeter, 2.9 centimeter from D6 to D8 vertebral body without interspinal extension. So urinary VMI was normal, and metastatic workup was also non-metastatic. So this is INR stage 1, stage L1. So this question, Dr. Chan Hon, so in this case of stage L1, what will line of management, like surgery was surgery and chemotherapy both?
Mm, I think, as you said, it's a L1 tumor.
Yeah.
Then I would actually go straight for upfront surgery. And whether we should add on chemotherapy again, we look at the biological markers. Those are very important nowadays because that helps predict whether this tumor is going to relapse or recur. So yeah, I think in terms of the OMS symptoms, no, those are not going to. I think I need to Dr. Vikramjit to comment on this because I don't think that the chemotherapy will help abate the OMS symptoms.
Yes, is there any role of observation in your stage 1 tumor? If like we treat the child for OMAS with ECPH and all, so can we just observe this child for remission of this mass? Just a query, sir, just a curiosity.
I would just remove the tumor because this is not a difficult surgery. And I'm not sure that by removing the tumor, will it help? But I think that the risks are not high. I would go for the removal. Is there a role for observation? Maybe. I'm not sure.
Okay, sir. So question to Vikramjit, sir. How do you manage OMA and what will your prognosis in terms of neurological outcome and sequel?
So OMAS is one of those entities which is very interesting because essentially it's due to off-target. It's the body's immune system cross-reacting as the nervous system, as opposed to the tumor. But these tumors are almost always favorable biology. Like, the interesting thing about OMAS is like, whether or not you resect them. And unfortunately, the effects are typically not reversible. So when you resect the tumor, whatever damage has been done so far doesn't revert upon removal of the primary, which is often very small, or like as in this case, or may not even be easy to find, like it's a hit and run, that the tumor has been has shrunk down to the size where you can barely see it, but it's left a lot of neurologic impact. And I think if we do resect this, we need to just let the family know that the neurologic sequelae and neurologic issues are not likely to reverse. They shouldn't go into this expecting reversal. Like, in terms of prognosis, the prognosis for these patients, it's there may be some amelioration over time, but it's rare to see a recovery from OMAS. And given the small numbers of patients, it's hard to make generic sort of sweeping statements. But we have not seen patients who come back to normal function. In terms of neurologic outcomes, I would encourage anybody involved with these patients to involve a good pediatric neurologist, because they are going to need ongoing kind of monitoring and follow-up, because the family is going to constantly wonder and worry about, when will the ataxia resolve, how will the ophthalmic symptoms do over time. So if you have a pediatric neurological colleague working with you, it's helpful. Otherwise, you can follow them yourself for late effects. But either way, they will need long-term follow-up.
So one more question, sir. Is there any any parameter or any way we can actually predict the extent of neurological outcome, like the extent of treatment, just surgery or surgery with chemotherapy and chemotherapy radiation all, or the time of radiation of these patients? Is there a relation with the outcome of these children with respect to extent or presentation of time presentation and all?
So to go back again, I mean, these patients should not typically be getting aggressive therapy. Like, I mean, in terms of, you mentioned radiation or like, cycles of chemotherapy. But I think a lot of people look at the OMS patients and they think about cord compression, they think about other similar neurologic deficits. But these are not deficits related to the tumor compression per se. And they should not be receiving chemotherapy, like, with a goal to try and shrink the tumor, because that is unlikely to happen. And it's not going to necessarily benefit the patient in any way. I mean, there have been some people have looked at antibody therapy, like, different antibodies, not the ones we just discussed or mentioned, not anti-neuroblastoma, but with regards to amelioration of symptoms. But I'm not aware of recent work in this area, so I don't want to commit myself. I don't know if Dr. Chan has any recent experience on that. I haven't.
No, I don't. Thank you.
With
Thank you,
IVIG.
sir. So take it to further cases, I'll hand over to Dr. Saumitra.
Yeah. So can you hear, sir?
Yeah,
Yes.
yeah.
Yeah.
Audible.
So our third case, it is treated in our institute. So 3-year boy presented to us on 13th of December with the chief complaints of basically a backache and inability to stand for almost 2 weeks. So on that examination, the bilateral lower limb power is 2 to 3 by 5 and not able to stand. So this is the usually we follow this kind of investigations, the LDH, ferritin, spot VMA urine. And because most of the time patients comes with investigations, and we saw that we are dealing with a neuroblastoma. So basically it is a thoracic neuroblastoma, and we can find out by seeing the scan, there is an encroachment through the neural foramina and involvement of the spinal canal. And it is what we have described that IDRF, it is more than 1/3 of the axial diameter. And in this kind of scenario, the question to me, Vikramjit sir, what we should do further in aspect to the one is the neuroblastoma along with the spinal cord compression. And Chanhan sir already discussed the things, but still we'd like to hear from you, sir.
So as this has already been very briefly discussed in Dr. Chan's talk, I mean, I think it's reasonable to start with chemotherapy, but this is not something where you should delay if you see further progression of neurologic symptoms. So I would start with carboplatin etoposide chemotherapy. Like, within a few weeks, you should be able, you don't expect to see dramatic recovery in these patients, but you do expect to see response in patients who are going to avoid laminectomy or avoid surgery, upfront surgery. So if you administer carboplatin etoposide, I would rescan within, these are like 3 weekly cycles. I would rescan within about 4 weeks, 4 to 6 weeks, because you really want to confirm your tumor is reducing in size. And clinically, you want to ensure that you are not seeing progressive weakness. This is somebody where you do want to talk to your neurosurgeon. And if there is worsening of symptoms in spite of being on chemotherapy, then you probably want to consider laminectomy. And I'll defer to Dr. Chan on that. Sort of, you can give sort of emergency, sort of 5 or 6 gray of RT, as well as another option if you don't have easy access to a neurosurgeon, like, so for centers where your neurosurgeon may not be available, like, in a rapid fashion, then you can certainly, some tumors will respond to 6 gray of treatment, but that is again, for patients who are showing progressive disease, or where you're, in this case, you're concerned with the bulk. And because the fact that already you've lost function, you don't want to get to the point where the child is paraplegic.
Can I ask one question, Dr. Vikramjit?
Please.
Yeah, actually, in these cases, Dr. Vikramjit, if you'll agree with me, that the time when the child is presenting to you or in the hospital, how long the paraparesis or paraplegia was present, that is also an important factor. If it is a very recent origin, then I think we should be very active in managing the paraplegia by giving
you brought up a very important point.
But if the patient is already paraplegic for last 1 month, say, then I think the damage has already been done in these cases, and the chances of recovery are very, very low. I hope you agree with me.
No, you brought up a very important point. The duration of symptoms is definitely sort of, a key in how you decide in terms of approaching these patients. That patients, unfortunately, who often come to us late, who have had significant paraparesis or even paraplegia, the recovery of those patients, the likelihood of recovery is much, much lower. In fact, the ones who come with complete paraplegia, I have not seen recovery. Like, even after laminectomy and chemotherapy, those patients don't recover. If you have patients who have paraparesis, it becomes a little more of a gray area, because then you're trying to figure out how long have they had these symptoms for, and you want to avoid them getting to a point where now they've lost complete function. So, but I agree with your point. It's well taken.
Yeah. Thank you.
So here what we followed, that steroid treatment followed by chemotherapy, and we also gave the child to the kind of a radiation, but still there is no improvement, and we repeat the scan that still there is a compression. So we went ahead and involved so I specifically mentioned this date due to the same reason. And we evaluated by doing MRI, and we took an opinion from our neurosurgeon in-house. And we went ahead with a laminectomy and decompression, though we discussed this matter with the parents, telling that maybe your child will not able to regain the power and able to walk. Most of the time, our parents, what we can see here, rather than the tumor treatment, they think if you treat, probably my child will able to walk everything. But most of the time, what Vikramjit sir mentioned correctly, we don't able to see this kind of result because our presentation is quite late. So can you go for the next slide? Dr. Kumar? Yes, ideal time to intervene, and does the histology guide in this? Any comment on that, sir?
Okay, so in terms of intervention, I kind of agree with you that yes, when initially there was some power, and then after giving the steroids as well as the chemotherapy and radiotherapy, the power became zero, right? So that is actually a deterioration. So in view of that, then yes, I think it is reasonable to offer surgery, and I believe that was what you have done. In terms of the subsequent recovery of the neurological functions, I think there are many factors here, as what we discussed, the duration of the compression, the ischemia of the cord, etc. So other than that, I think after the spine is dealt with, I think the next part is to think of when to remove the thoracic component, right? So finish the what we say is the pre-op chemotherapy, whether it is 2 cycles or 4 cycles, and then go on to the thoracic portion of it. Histology guiding this, I think the only thing that will prevent me from doing the thoracic component any earlier is whether there is a presence of metastases in other areas. If the metastatic diseases has been well controlled, then I would do the thoracic surgery earlier. So I hope I've answered those questions here.
So we did that surgery and the cord appears lax, but there is not much significant improvement following that surgery. And by that time we got all kind of reports related with the small segmental chromosomal anomaly, what kind of risk factor we can put this child. And usually, rather than going upfront, we prefer to give chemotherapy and then go for the surgery, what we follow here. And only if there is a very small tumor and there is a L1, then only that case we go for the upfront surgery. Otherwise, most of the time we prefer to give chemotherapy and then go for the surgery. So we follow that intermediate risk chemotherapy, then surgery, and at present the child is in follow-up. But yes, the child is still have a bowel involvement and there is a poor neurological outcome. So here also there is another survey. This is that was a thoracic neuroblastoma, and here we can see when we are dealing with a cervico-thoracic neuroblastoma, but it is a stage M because of the upfront bone marrow involvement. Here we started that the results and started the chemotherapy, but during the initial evaluation the child developed kind of a or 4/5, and there is a brisk reflex, deep tendon reflex, and 3 and truncal weakness, and this is the scan. Sir, anything, your points about this kind of case? Shannon, sir?
So with what appears to be cord compression.
Yes.
Right. So the question is whether to treat medically or to perform surgery, to decompress the spine, not the thoracic portion. All right.
Yes. Yes.
I think it depends on your situation. So I think it is reasonable to start with medical therapy first before doing surgery.
So here there is excellent response starting the chemotherapy, and because it is a high risk, what we follow is going for the rapid COGE. Then we still evaluate the bone marrow aspiration and biopsy to prove it, and with supported by the PET CT as well as the MIBG, the child was on remission. Because it is a localized disease, and we specifically asked for the MRI, and we can see the scan. It is excellent. It is responded with the chemotherapy. And we went ahead with the trapdoor incision, what already discussed by the Chanhan sir. And what is your opinion, sir?
Yep. So from the scan, am I right that it extends all the way up to probably T1? Yes. Right. So yeah, so in the apical part of the thoracic cavity, I think trapdoor is a very good enables us to have very good exposure. It reveals all the subclavian vessels, which most of the time will be encased, and it provides a very good exposure for us to clear the tumor. So I would do the same, yes.
So we completed the surgery, And
It's the first time.
Yeah.
It's the first time they're seeing each other.
Yeah.
When he proposed, now he didn't see her.
No.
okay, so then we went ahead with the autologous stem cell transplant, which is done on 29th, and the surgery, and lot of time. I mind the next question about the timing of the treatment of the
Preventing from exploding. It's preventing from exploding. You know, it's gonna explode. Like that.
Ankita, can you please mute?
yeah, can we just go ahead with the stem cell transplant as well as the radiation?
Supposed to be 1 hour.
Can you just go for the next slide?
Seeing her smile and seeing her look at me like.
Yeah, so to Vikramjit sir, about the duration of the treatment, the completion, and as well as there is any long-term effect on this on the survival of this duly finished the time, the treatment.
Saumitra, you're going to have to rephrase your question.
So
You know,
that any
you've
time
asked
limit, anything is there about this duration of the treatment? So starting the chemotherapy, going for the local treatment, then autologous stem cells transplant, and followed by the radiation and that immunotherapy, what we just now discussed.
So the general duration of treatment usually ends up being about 8 or 9 months or longer, especially if you're giving retinoic acid or immunotherapy at the back end. Like, you know, as far as effect on survival, like, you know, with regards to, again, whether you had to take a break in between because of surgical complications, it shouldn't have a significant impact on survival. I think it's hard to be categorical. It's going to be case by case basis or case by case dependent.
Okay. And I can see one question from Dr. Shalini Mishra about that, what we did with the intraspinal part which we left behind here. Sir, any in this particular case, we didn't do anything with that part. We went till the level of the neural foramina and we left behind that part. Sir Chanon, sir, any comment on this?
Yeah, I agree with you. So I think in many cases where there's this a little bit of remnant disease in the intervertebral foramina, we tend not to go all the way out to just dig that little bit out of it. I think it is acceptable to have some residual and just follow up with in your subsequent scans. Most of the time, they don't cause problems. However, we have seen some reports mention that some of these tumors actually expand or increase in size, especially the well-differentiated or the more benign versions. Sometimes over time, they actually expand in size and cause neurological symptoms. And in those situations, yes, then go ahead and have to clear them to do a laminectomy and to clear the tumor that's causing compression.
Yeah. And probably I'll add to that, if the residual, typically these should be MIBG negative or PET-CT negative by the end of induction. So in those situations, leaving them behind is the wisest thing to do. If they have PET or MIBG positivity, you know, when you go in for autologous transplant, you should consider radiating that part when you come at the back end. But that's a little controversial as to how many sites you should radiate, but you really should. I mean, this will be a standard going into transplant to ensure what the status of the residual disease is.
Okay. Dr. Amit, anything you want to add? Yes.
So, thank you, sir, for this discussion on cases. So, we can take some questions now.
I think you can take quick questions. We are already over time, but
Yeah. So
we can't have Dr. Chan and Dr. Vikramjit again together. So I think we can have few questions.
that's the thing, yeah. So the one question from you, Dr. Monica, you can ask, like, does giving chemotherapy help with better cervical planes and blood loss?
Yeah, I wanted to know
Dr.
about the
Monica,
cervical. Yes, sir.
Yes, definitely. Giving chemotherapy will help. Definitely reduce the vascularity of the tumor, especially in neuroblastomas, whereby we have to split the tumor to remove them when they are encasing structures. So when you split them, they bleed. So if you have given chemotherapy, you tend to reduce the amount of blood loss, and it makes your surgery a little faster.
there is one question from Dr. Akshay Kalawan. He has asked about the role of radiotherapy in intraspinal extension. Dr. Vikramjit, can you answer, sir?
So, role of radiotherapy. So, high-risk patients are routinely going to get radiation therapy to the tumor bed. As far as low risk or intermediate risk, we typically do not radiate. But there may be some patients in intermediate risk category with unfavorable histology if you have a large residual, or you have disease which it's unresectable, large residual, you can consider giving radiation. That's going to be after a lot of discussion in your team. It's certainly not the standard for low and intermediate risk.
Next question is from Dr. Simirathan. He has asked, a ganglioneuroma residue from pelvic tumor in epidural space is symptomatic. Is neurosurgical intervention required? If not, how frequently you need to follow it up?
Maybe I should answer this one. So
Yes,
if
sir.
it's a ganglioneuroma, so I think if there are no neurological symptoms, you monitor according to what you would be doing if this was neuroblastoma that's being treated. And how often? Maybe 4 months, 6 months initially, and then subsequently it can stretch on longer, because if the tumors don't grow much in the first year or two, they are not likely to grow very much subsequently.
And what if it's ganglioneuroblastoma? Like, it's the same thing for both of them.
Ganglioneuroblastoma, then so I think it's the same. As we follow them up, if we find that the rate of change is not significant, that means after reviewing them every 4 monthly for the first year or 2 years, you find that they are about the same size, then similarly, your third year onwards, you just scan them, perform scans at longer intervals.
Yes, sir. So this is
a lot of debate about the costs of scanning and follow-up and surveillance scanning. But I agree with Dr. Chan, the first 2 years are first 1 year, in fact, is your critical one. Post completion of treatment. Patients who are stable at the end of the first year, and definitely by the end of the second year, you don't need to do frequent scans.
This is a follow-up to the first question I asked. In case this intraspinal disease is progressing in spite of chemo, then do we go for radiation?
Sorry, the first case.
First case, not first case. First question I asked, like the role of radiation in intraspinal tumors, extension of the neuroblastoma. So this is a follow-up that question. So if this is progressive, despite chemo, do we go for RT? In case of maybe L2 or L2 tumors.
That's a challenging question. I think you're going to find that many tumor boards will say yes, but it's done out of a sense of, now, are you talking about progression despite being on chemotherapy? I assume that these patients are receiving standard chemotherapy, whether etoposide carboplatin. If it's only been etoposide carboplatin, you can switch to something more aggressive first, like, such as Keto, before taking a final call. If you find they're progressing despite etoposide carboplatin and Keto, then these are probably biologically aggressive tumors. And it's unclear whether radiation is going to give you any long-term cure. But I think most or many tumor boards will then recommend giving 21 to 36 gray of radiation. Dr. Chan, feel free to jump in as to what you've seen in your
Thank
experience.
you. So you are actually referring to intraspinal tumors, am I right?
Yes. Yeah.
I apologize. It's a limited. Yeah, sorry.
Yeah.
Go ahead.
So I think that's going to be difficult. I think if you are going to, certainly radiotherapy is a good option, but I would also consider surgical removal. If this tumor, if you say there's progression, that means there must be a significant increase in size, including even loss of neurological function. So I would consider surgical decompression as the alternative. For surgeons, we tend to get a little nervous if radiotherapy is given and then subsequently we go perform surgery at the same location, because it makes the dissection a bit more difficult, because radiotherapy tends to cause a bit more scarring, fibrosis, makes it very difficult to differentiate normal and abnormal structures. Yeah, so but yeah, so I would actually want to consider surgery rather than radiotherapy first.
And I agree. My apologies. I didn't realize that you specifically were referring to the intraspinal
one.
case. Right.
So
No,
I think
next years. You want to decompress these patients.
yes, sir. So next question, Dr. Monica. So in many cases, in case of intraspinal extension, we tend to leave behind the tumors because the thoracic and abdominal component. So what is your experience of this strategy in the long term? Any of you, sir? Any one of you?
I think he's already.
Intraspinal extension, and then you do the abdominal or the thoracic component, and you leave some behind, right?
Yes,
So
sir.
if they are asymptomatic, we'll just continue to observe them. Very often when you finish the chemotherapy or finish the whole course of the whole protocol, the tumors inside the spine would be so small that you will feel comfortable observing them. And we certainly will deal with them if they do progress or they grow larger. But otherwise, I will just observe them.
So there are no further questions.
I'll just take two questions. Sir, the Dr.
Yeah.
Sidney has asked, is there any role of steroids along with chemotherapy in case of spinal extension? Are there any recent guidelines? I think it is it covered?
No, it's not covered.
Okay.
Yeah, I think I missed that question.
So role of steroid, like, I think instinctively we all give steroid for any kind of anything compressing the CNS system, but it's unclear to me there are any clear-cut guidelines on this. So, like, the dexamethasone gets written up almost routinely when you see nerve or a cord compression. I'm not sure in this situation how much it actually benefits the patients, but I'll be honest and say I don't know if there are clear-cut existing guidelines for this. Dr. Chan, maybe you can weigh in.
I'm not certain as well. I think most of the time my neurosurgeon colleagues, whenever there's some nerve compression, would like to give some dexamethasone, to reduce swelling of the nerves. More for that reason rather, it is definite. I don't think it's the therapeutic effect on the tumor cells.
It's more for therapeutic effect on the neurosurgeon,
yes,
rather than on the right.
Okay. Can we just move this slide? So the one last question I just had, because we had renal hypertension. Hypertension is one of the pain.
Okay, yeah.
So would you like to comment on pre-op hypertension management, because some patients are in 2 drugs and 3 drugs? And one more thing, for example, just in these cases where renal vessels are encased, and somehow you're not able to remove complete tumor, and some residual is behind this thing around the renal artery, and the patient is having hypertension. So most of the times, I think, do we save kidney? I mean, do we save kidney or we remove kidney thinking that hypertension would occur? So basically the hypertension thing, if you could elaborate both medical and surgical aspects.
I'll let Dr. Chan go first on this.
Okay, thank you. All right, so the cause of hypertension could be either the tumor is producing secreting and causing hypertension, or it's due to the compression of the renal vessels. And the third one, which I have encountered once, and that was a concomitant paraganglioma at the same time in the cells of neuroblastoma. So I think if it is non-secret, even if it is secreting, I think by removing the tumor, it gets better. Sometimes some of these tumors, if you give chemotherapy, they mature, and as they mature, they produce more of these substances like norepinephrine. Then yes, in the end, you get you find that the hypertension is worse. Or some started without hypertension, but as you give the chemotherapy, the hypertension develops. So in these situations, then yes, removing the tumor is going to be useful because you are removing the secreting the source that's secreting these hormones. So for the tumors that's compressing onto the blood vessels, removing the tumor would also assist or help make the blood pressure better. But I think in most of these cases, because of the secretions, the hormones secreted, many of these blood vessels are so used to being in a vasoconstricted phase. So even after removing the tumor, you may still find that you still need the high blood pressure, the hypertension, because it takes a long time before this hypertension actually, or the patients actually be able to get off the antihypertensives. All right, so at least that's what I encountered. Maybe Dr. Vikram, what do you think?
So this is one part where maybe we will differ slightly. I don't, not a significant amount. I agree completely with all of your observations. That's what I've seen as well. But in general, chemotherapy, if it helps shrink down the tumor slightly, and if it helps sort of reduce some of the compressive effects, may help relieve some of the hypertension as well. So whether or not to go for upfront resection will depend a little bit, I think, on the accessibility and resectability, and on imaging as you point out correctly, whether you have a lot of renal artery compression and other factors, as opposed to simply catecholamine secretion. So I would be inclined to start chemotherapy upfront, and then depending on how, but it's going to depend a lot on, because you can see there are 3 different cases with, I assume these are 3 different cases, images, with very different tumors in regards to resectability, and then coordinate closely with the surgeon with regards to what needs to be done over the next sort of, immediately next 2 cycles, next 4 cycles. As far as antihypertensives go, I don't have a favorite one. You can use whichever one you're comfortable with. But just keeping in mind, your goal is not to bring the blood pressure completely to normal, but just to reduce it towards the upper So sort of bring it down towards 75th percentile, because once the catecholamine secretion stops or the renal artery pressure is relieved, you're going to get a precipitous drop otherwise later on, which can cause problems.
Yes, I agree with you, Dr. Vikramjit. I think I missed out the earlier part that yes, when there are IDRFs, I would give chemotherapy. Yeah, so it's not it's more like the talking about the strategy if we are talking about surgery and how surgery will affect it. Yeah, definitely chemotherapy will be required.
At the end of an hour and a half, I think we're both at the same point.
Yeah.
So we have come to the end of this webinar. Thank you, Dr. Chan, and Dr. Vikramjit, for giving us valuable time to teach us, to guide us, to go through this. And it was a nice session. We all enjoyed, we all learned a lot from this. So, and hope we'll sit with you soon for a similar session on different topics. So, thank you. Thanks a lot. Thank you all.
Thank you for the excellent session. Thank you, everybody, for the excellent session.
I'm really grateful for Dr. Chanhon and Dr. Vikramjit to agree and come on the stage. Thanks a lot to both of you, and we had really nice sessions. Thank you, everyone.
Thank you.
Thank you. Thank you, everyone.
Good night,
Thank
sir.
you.
Good night.
Good night.
Night.
Good night, everyone. Good night.
Yeah, good night.
Chanhon, so you have it's what is time there in Singapore right now? I just wanted to know.
This midnight. This
Midnight.
12:15. Yes. No
I
problem.
hope you have a good night, sir. Thank you.
Okay. Okay.
Right.
All
Thank you
right.
so
Good night,
much,
sir. Good
everyone.
night, sir.
With all your permissions, we are concluding the session over here.
Thank you,
Thank
Uncle.
Thank you all.
Thank
Bye.
you. Bye.